Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Awesome. Thanks, Brian. And yeah, very happy to be here today. I did college at Gonzaga, so hi to all the Spokane folks. And so just happy to be back to the Pacific Northwest. So my talk today is going to be on medications for methamphetamine use disorder. I have no conflicts of interest. So before I begin my talk on medications, I just feel like I need to highlight the elephant in the room is that unfortunately at this time, there are no FDA-approved medications to treat methamphetamine use or really any stimulant use disorder out there currently. So we're going to be talking about off-label medicines. So all that means is that the evidence I'm going to show you is not great for these medicines. There hasn't been any slam dunk RCT trials. It's going to be limited. But I think for many of us, just reflecting, we use off-label medications all the time, and especially for our patients with high-risk substance use, the risks of not using these medicines often outweigh the risks of using them, and the benefits are great. So hopefully today you can take away it's okay to use non-FDA-approved medications for methamphetamine use disorder. It wouldn't be right for me not to talk about the approved medications or the approved treatments, I should say, for methamphetamine use disorder. And the first slide, gold standard, is behavioral treatment. So it won't be the topic of my lecture, but please know for stimulant use and methamphetamine use, specifically first-line treatment is behavioral. So motivational interviewing, we can all do this in clinic with our patients. Contingency management programs are gaining more and more traction because they do show to be the most successful, as well as other types of therapy like CBT. If you have questions on any of those methods, SAMHSA has a really well-published guide. It's in my sources cited. You can take a look at it. But again, not the purpose of what we're going to talk through today. All right, so what are my learning objectives? I wanted to keep them pretty straightforward, things that we can take away pretty easily from this talk. I want you all to be able to identify 3 non-FDA approved medications to treat methamphetamine use disorder after this lecture. I want you to be able to understand how to dose these medicines. And I want you to also recognize that there are some medicines for methamphetamine use disorder that also treat co-occurring other substance use disorders, and know when you might want to treat a patient for both of those things. I start every talk like this with a case, so we're going to think about Eddie as we go through our medications today and then revisit his case at the end. So Eddie's a patient of mine I see in clinic here in LA. He's 28. He has a history of HIV, and he's currently on a PI-based regimen with some Tuza. He has intermittent medication compliance, and he's in clinic today requesting medication for his methamphetamine use disorder. For history, he smokes crystal methamphetamine daily. He denies any IV drug use. He has tried to quit his methamphetamine use many times in the past, unsuccessfully. Unfortunately, he's been in and out of rehab multiple times and has tried to engage in counseling and therapy, but has not found it successful. So he's really coming to you for medication. He denies any other stimulant use, and he does not use opioids. He does report drinking high quantities of alcohol and smoking tobacco cigarettes. Simtuza isn't his only prescribed medication. So I want you to think about this case. Patients may be similar to this, what you have seen, what you've heard about, and then at the end, we're going to talk about what treatments for methamphetamine use disorder, specifically medication that we can offer Eddie. So here's what I'm going to talk about today. I can't talk about every medication that's ever been studied for methamphetamine use disorder. There's a lot. I'm going to talk about what I call preferred medications. These are easy medications you can use in a primary care setting. You don't need a restricted or a DEA license for these medicines. So we're going to talk about Mirtazapine, Bupropion, Naltrexone, and Topiramate. Other options that many people use are prescription stimulants. If you have questions, we can talk about those at the end, but I'm only going to have time again to talk about these first 4, which I do think are the more important ones to talk about for this audience. If you want to deep dive into this, I find this very interesting, and I like to look at really every medicine that's been out there. There's been this really wonderful systematic review that I do highlight a lot throughout this talk, done by Krista Siegfried and her colleagues in March of 2020. It's a very well done systematic review looking at all pharmacotherapy used in RCT settings to look at methamphetamine use disorder. The take home is that there's nothing great, but they go through everything. And so if you're like, I ever wonder if X medicine was used to treat this, you can look at it in this systematic review. All right, so we're going to start. I kind of have structured these based on the way I think about the clinical utility and how easy it is to start. So I'm starting with Mirtazapine because it's a pretty easy medicine to start in folks. And it's often my first line medicine for just to get everybody up to speed. What is mirtazapine? It's an antidepressant. It's commonly dosed at night. It can be helpful for insomnia, and it can be helpful in patients who want to gain weight. So I think about it often in many of our patients with HIV who are maybe malnourished and are wanting to gain weight, or patients with methamphetamine use disorder who also are malnourished and need to gain weight. So it can be helpful in those situations. It hasn't been studied a lot. There have really only been 2 small randomized controlled trials on mirtazapine. But again, I like this for patients with HIV because it has been studied in what I would say our patient population. So these studies were done out of San Francisco in men who have sex with men. The first study was done with about 60 patients, and the second study was larger. It was a replication study. It included MSN as well as transgender women. They did show significant reductions in methamphetamine positive urines as well as decreased sexual risk behavior in both of these studies. So the replication trial sort of confirmed the results. We're not seeing abstinence or no methamphetamine use. We're really just seeing harm reduction and sort of decreased use. But it has been shown to be effective in those 2 studies. The dosing is pretty straightforward. You start with 15 milligrams QHS, and then you increase to 30 milligrams, and that's the max dose usually for methamphetamine use. I usually do it after 3 days, but I think the studies did it after 7 days to go up to the 30 milligrams. There's really no interactions with ART that I worry about. If you type it in terms of the interaction checker, it will show a theoretical interaction with protease inhibitors, just given they're metabolized through the same CYP enzyme route. But I have patients on protease inhibitors that I use the 30 milligrams, and I've talked to my pharmacy colleagues, and there's been no issues or contraindications to that dose that I have found. So I use mirtazapine the same in really any different ART. So that's mirtazapine. It's sort of my go-to first-line treatment for most patients. What about next? The second medication to talk about is bupropion. So a reminder, bupropion, brand name Wellbutrin often. This is, again, another antidepressant. I like this medicine. If someone wants a more activating antidepressant, people have heard about this. Maybe they've been on it before. I also really like this medicine if someone has a tobacco use disorder, since it is FDA approved for that indication, and many of our patients, have tobacco use disorders. What is the level of evidence for bupropion? There have been a few more studies than for mirtazapine, but really not that many either. 2 small RCTs in the past did show some reduction in methamphetamine use in what they called low-level users, so people who didn't meet a full criteria for a substance use disorder. So that was promising. There have since been 4 RCTs that have looked at individuals who have methamphetamine use disorder, and the results have been a bit of a wash, have shown some reduction, but not significant reductions in methamphetamine use. Just highlight this one study from 2014 that again showed no difference between the placebo and bupropion, but they did show low adherence to the medicine, and then when they studied the small number of patients, only 13 patients who were actually adherent by plasma levels, they did show a significant difference. So I think it just reminds us that often many of our patients have low adherence. We think about similar patient populations with PrEP and things like that. And so just helping patients to adhere and find a medicine they can adhere to is often the most important thing I think about. So how do we dose bupropion? It's the same as you would for tobacco use. So you're using the extended release formulation, 150 milligrams daily, and then I go up to BID after 3 to 7 days, depending on how well they tolerate it. I really don't think about interactions with bupropion at all unless someone's on other medicines besides just general ART. There are interactions with older NNRTIs. So if you have someone on efavirenz, if they're still on atripla or something like that, you may see a decrease in bupropion levels if they're co-administered. And so you could consider increasing the dose of bupropion if they're not getting the intended effect on the 300 milligrams a day. I really think about this medicine, though, like I said, in individuals who want to stop tobacco use, because I find that can be very motivating, and then hopefully it can help out a little bit for their methamphetamine use. All right, number 3 out of 4, so we're getting our way through, naltrexone. I would think probably you've heard a little bit about naltrexone, just given its use for other indications, but I'm just going to reiterate and remind us what naltrexone does. So naltrexone is an opioid antagonist, so you can see it's this bottom one down here in this picture. So methadone is the full agonist, bupropion the partial, and then naltrexone. I guess that says naloxone. I didn't think about the slide, but naltrexone's the same as naloxone. It's a full antagonist, and so it blocks the mu opioid receptor. It's FDA approved for both alcohol and opioid use disorder. So it's exciting, right? We think about that this medicine could be helpful for other substances as well. I'm not going to go into the details here, but there have been 5 RCTs with naltrexone, and the results have been fairly conflicting and no slam dunks. Some decrease in methamphetamine use, but, not a lot. If you're interested in how to dose it, though, dosing it the same as we do for alcohol or opioid use disorder with 50 milligrams daily or 380 milligrams IM monthly. That's the Vivitrol formulation. Remember, they can't be on opioids while they use this medicine. It's really got no major ART interactions. And I'll probably just leave it at that. I feel like I had something else to say, but maybe I'll jog my memory in a little bit. So you may ask, what about combining certain medicines? And some of us may have heard, this kind of was popular in the news not that many months ago, about a combination naltrexone and bupropion. Because sometimes medicines work better together. And so this got a lot of buzz because it showed some positive results. So it was a study done, multi-site study done with little over 400 patients, where they combined naltrexone and bupropion versus placebo, and they did find significant decrease in methamphetamine positive urines in the treatment group. It wasn't a lot, it wasn't like a ton of patients. I didn't calculate the number needed to treat here because they didn't show it in the study, but it was significant, and so it did get a lot of buzz. I remember what I was going to say before, and so what I was going to say before is what's nice about naltrexone is that once-a-month formulation is nice for patients that have trouble with adherence. And I think about that a lot for my patients, some of my patients who have more chaotic lives, and certainly many of our patients who use methamphetamine fit into that category. So that's what I like about naltrexone if they're just really having a hard time taking a pill. But what's funny about this study specifically is they used very different dosing regimens than what we commonly use. So they did IM naltrexone every 3 weeks, and then they did a very rapid up titration of the bupropion to 450 milligrams a day. And so it's not really realistic in my current practice setting to give I don't think insurance would cover this for the naltrexone, and it would be hard to up titrate someone that quickly, I think, with the side effects of bupropion. So I take these results with a caveat that, hey, maybe that we wouldn't get these results in our usual dosing. But in practice, I'm actually trying to kind of combine these medicines a little bit more, because often many of my patients will have a tobacco or an alcohol use disorder too. And so I have been trying them together with some of my patients with methamphetamine use. And my N is pretty small, so I can't really give you much, but I have one patient that it seems to be helping her. All right, so then the final medicine I want to talk about is Topiramate or Topamax. This medicine was first FDA approved for seizures, can be used for headaches, can be used off-label for other certain substance use disorders such as alcohol. Very few number of studies for Topiramate, not so surprisingly, 2 RCTs. One showed no difference, one showed some reduced severity in methamphetamine use. The majority of these studies are going to show decreased use or decreased severity. Not very many studies are going to show abstinence. And so I think about them as more harm reduction medicines. Let's get my patient from using meth daily to maybe using meth once a week or less than that if I can. You dose it at night, 25 milligrams QHS, and you're going to titrate up 25 to 50 milligrams increments to the 100 twice a day or 200 QHS dosing. I always have to look these sort of dosing algorithms up, but you start low at 25 milligrams. There's no major ART interactions, which is great. The only thing to think about is this is teratogenic. Sometimes I forget about that. So you would not want to be giving this to a woman of a childbearing age who does not use contraception or who is not reliably using contraception. So be cautious about that and have that conversation with your female patients. All right, so we went through that really quick. Hopefully I'm staying on time, but these are what I would consider my sort of preferred medications for methamphetamine use disorder. And again, some people do use prescription stimulants. They have had about the same level of evidence as these other medicines and are worth a shot, especially if you think about someone having maybe a co-occurring ADHD or something like that. So talking about Eddie, what would I offer Eddie? I'd be interested to hear what you guys would offer Eddie too. But, I think about Eddie as, having a diagnosed methamphetamine use disorder, but could he have something else going on, right? He's telling you he drinks more alcohol. He's telling you he uses tobacco. Could he have one of those use disorders too? So we have a bit of options to play around with. My first line is usually Mirtazapine, just given, like I said, it's got sort of limited side effects. Most patients tolerate it okay, as long as you're telling them to take it at night. The sedating side effects aren't that great. So I usually start with Mirtazapine. If he said, hey, I really want to stop tobacco, or hey, I really want to stop alcohol, then I'd start with one of those two. You can always add medications. So, this is all sort of expert opinion. It's not based on evidence, but I might start someone on Mirtazapine, then add bupropion, and then maybe add naltrexone. So I do have patients actually on all 3 doing okay. It sort of just depends on the patient and what their goals are. and maybe what their co-occurring substance use is. As just a final note, I just want to remind everybody that, especially out here in California, I'm not as sure what's going on in the drug supply in Washington, but we have seen a lot of unintentional overdose of patients using stimulants, which is contaminated with opiate products like fentanyl. And so it is part of the drug supply. And so just knowing that and being able to educate our patients about harm reduction purposes as well, I will try to, for my higher level users, prescribe naloxone to them as well, just to make sure they know in case of an accidental overdose. And so naloxone is an opioid overdose reversal agent. It would be for telling patients that their drug supply might be contaminated. So I'd like to remind them why. I don't think you use opioids. I know you use methamphetamine. It could be contaminated. And so I do prescribe that more commonly now to my patients here. And I think it's common in our community to do that as well. So that's basically it. Hopefully, again, we got this done in 15 minutes. Some take-home points. Behavioral treatment is definitely the first-line treatment for methamphetamine use disorder. Please think about those resources. Think about motivational interviewing. We can all do this in clinical practice. Contingency management is great too, or other sort of CBT programs. There's several off-label meds with some efficacy for methamphetamine use disorder, and I am using them quite a bit in my patient population just because we don't have a whole lot else. And patients want this. They want to get better, and so I'm trying to help them with some of these medicines. Mirtazapine is usually my go-to first-line medication, especially if patients are okay with sort of the sedation or the help with sleep and a little bit of the weight gain. But then I'm often treating many of my patients for co-occurring substance use disorders too. And so thinking about, hey, could this patient possibly do well on naltrexone or do well on bupropion? I didn't even talk about patients with opioid use disorder more specifically, but of course, if you have someone with opioid use disorder, offering buprenorphine or methadone is definitely important as well. So with that, I don't think I have any other summary slide. I guess I will leave it there and take any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.